Okay, good afternoon, everyone. So we are coming to the last day of IMCAS. So I hope that you are enjoy all the sessions here and also enjoy Bangkok. For me, I would like to talk about the area that many patients forgot to take care of them. One of them is hand and another one is neck. But so today for me, I will share you about the hand treatment, prevention, and also rejuvenation. I'm Dr. Sunetra Nityawathana from Thailand. Today, I would like to declare that there is no conflict of interest during my talk today. In the era of longevity, every patient, every people would like to look more younger without the obvious treatment. So the key concept of longevity is to preserving your skin biological structure and also natural resilience and natural repair. So, so many factors that are harmful to the hands, especially UV lights, and also daily activity like you washing your hands during the COVID paradigms or every day that you use your hands. But the treatment concept for hand rejuvenation, for me, I will tell the patients to keep hydration, and our priority is to improve the texture, volume depletion if they need it, and also remove the dyspigmentation. So many modalities that can treat your hands to look younger, even though the topical cream is also important, and it can deep down to the injectable and also the machine. Normally, I will grade the problem of the hands to the mild and severe. If the mild case as 0 to 1, it means like minimal problems to the patients. So we need about the preventive modalities. But if the patient has dyspigmentation, volume loss, and also wrinkle and laxity, it may be need go more further about the treatment and the aggressive one. So, which is the suitable techniques for each time of the case? I will show you the first case. Actually, this one, 35 years old female, it seems like she has a fine wrinkle, just only minimal. So this one I would like to treat as a preventive case. I use soft HA fillers in this case because a bit volume loss. Actually, in this year, the patients look more like spotty girl. Sometimes if you see some visible lines or visible tendons, it seems like more healthy. But in some case, in this case, the patient say that, oh, I don't want to see like more healthy. I would like to be like volume hands because in some patients believe that the volume and plumping of the hand is mean like prosperity in Sang Shui, okay? So this case, you prefer to use the volumization, so I need to use the soft fillers. But so many techniques that I would like to share, but normally I prefer the linear threading techniques because of the anatomy of the hands. Normally, the hands has anatomy like sponge, oh sorry, it cannot point out. It's sponge-like layer. If you inject boluses on the dorsum of the hands, it can spreading down and interfere with the functions of the hand, especially on the tendons. That's why I prefer to use like small linear threading. This one, it can be shown that if you use the bolus or threading is so big, it can moving downward because it seems like a sponge-like fascia. It's not a thick like fascia on the other elsewhere of the body. So the good layers that we have to place the HA is dorsal superficial lamina. This one you can spread linearly small amount because if you inject very superficial, it can cause the Tyndall effect the same as you treat under eyes. So this one is the base layer that you can treat. Here is the before and after cases. After HA fillers, I prefer to use the moldable and soft one. Okay, this is the preliminary results from my colleagues. They compare the biostimulator KAHA together with the HA in the treatment of aging hands. There are split side study. The left side, they will inject just only KAHA and dilute with the saline 1:1. And another side, dilute with the soft fillers. Okay, let's see for the results. As you can see, this is the preliminary results just only 4 weeks after treatment. It's look better on both sides, but when we follow up, it showed that moisturizer and roughness is declined, but it's not significantly different. As you can see, the blue lines is the pure KAHA, and the blue line is KAHA combined with the HA, and the red line is pure KAHA. So when the time passed to 3 months, it's still improved, but it's not difference between two groups. But if you take a look on another parameters about the wrinkle and volume depletion, it's quite different in significant way that the combination treatment can reduce wrinkle and can plump up the volume longer than the pure one. Move to the second case. This case, 50 years old. If you look at the hand, 50 years old is pretty much good compared with her age. So, but she complained that she has also like fine wrinkle and dry skin. So this one, I also use the preventive treatment with the Attilo collagen. The Attilo collagen actually is quite popular in our country now. Because collagen and fibroblasts, the cells that very important to stimulate the young and useful is fibroblasts, right? And fibroblasts is shrinkage and collagen is breakdown when the time pass or when the aging process can be occurred. If you inject the collagen, the fibroblasts will stimulate themselves like healthy fibroblasts. For example, normally fibroblasts can stimulate the collagen or improve the natural function by 2 ways. The first one is from mechanical stress. That's why you use the energy-based device, right? And another one is for the thermal stress. For thermal stress the mechanical stretch, you stretch with the collagen injection. But the thermal one is the one that you use with the EBD. So I prefer to use the injection with the collagen one. But normally, as you know, collagen comes to aesthetic market for 30 or 40 years, but it's not popular compared with the HA fillers because it's allergy and it's difficult to inject because we need to do the skin test, and the price is very, very expensive on that time. But now in the 4 or 5 years, they are developed the new one of the collagen we call Attilo collagen. It means remove the telomere peptides out, because the telomere peptide on the end of the peptides, it seems like fluffy. So our body feel that that's one is look like a fluctuate. So we can stimulate the immune response. That's why the new technology, it's remove the telomere peptides out, so we call Attilo collagen. In our market in Bangkok, we have 5 kinds of Attilo collagen that are available in our market now. But as you know, it's the collagen type 1, except Charisma is human recombinant 1. But the same Attilo collagen has different characteristics. This is the pictures that I scanned it by myself by scanning electron microscope. It's all Attilo collagen, but you know the structure is different. The first one is one brand. The second one is another brand. And the third one is another brand. It's the same Attilo, but it's different in structure. So that's why if you want to inject, you have to dilute, or the clinical application should be individual brands, okay? So for me, I prefer to use the collagen by diluted and injected under dorsum of hand to smooth and shine the skin. Because after I inject collagen, it can stimulate the new one. and adjust the environment of fibroblasts to enhance the healthy fibroblasts, not for the volumization. If the patient needs volume, I will shift to another modality such as HA fillers. It might be better. So I will show you the case. This case is 2-week follow-up after inject the collagen. So as you can see, it comes like a smooth and shine. Here, if you take a look closely on the knuckle, actually she has the quite dry and cracking skin, but after inject it's improved a lot. For the third case, this case is 62 years old female, is quite severe of wrinkle and loss of volume. So this one we need aggressive treatment. From me, I prefer to use HA filler for sure, but I use the RF energy to improve the wrinkle on the fingers also, because on the fingers we cannot inject any substance of HA because it's quite dangerous. So I prefer to use energy-based device. But for sure, energy-based device, if you contact the skin not properly, it can easily to get burns. Okay, for me, I use the RF energy with monopolar. Okay, this one is patent that it can move regularly on the pins. I will show you the videos. Okay, here it's not so hot, so the patient can tolerate. It's a little bit feeling hot, but not so pain. Okay, I do it on the fingers and also the dorsum of hands. It feels like you get a combable because it's patent technologies that it can move freely, so it's not burn. Okay, after that, in the same session, I inject the HA filler for volumization. For sure, this one is look very, very superficial, but actually it's on the right plane that I showed you earlier. Okay, this is the follow-up case, 2 months follow-up. Okay. I think I don't have no more time to share, but if you take a look closely, the patient's very happy with their hands. Okay, and also in the finger, the wrinkles on the fingers get improved. It's 2 months for follow-up. Okay, last but not least, we're concerned about the adverse event and complication. The one that I would like to mention you is if you inject the substance like KAHA or HA on the dorsum of hand, please advise the patients to avoid like strong movement like exercise or holding very heavy things because it can deep down and accumulate in the tendons area. So it can cause the delay pain on motion. Okay, hopefully that conclusion treatment can help you adjust with your case. Thank you for your attention.
Thank you, Dr. Sunetra. Since she is not available later,
Yes.
Hello.
if any delegate have any questions, please come to the microphone, please.
I'm sorry that I have something to go. So if you have any question, please feel free to ask me, or you can contact me via email or Instagram if you like.
I have a question, yes. The soft HA which you use, how long does it last? And compared to collagen, how long does the collagen last?
Okay, actually for me, soft HA, you will see the immediate results, and it can last 6 to 9 months, not more than this. But collagen, you will see just only smooth and shine, but no volumization. But it can improve when the time pass up to 6 months. It's still ongoing improve.
So you repeated 6 months?
The pictures that I show you is just only 2 months, but when I follow up to 6 months, it's already perfect.
So second session you call it 6 months. When do they come again? They ask you, when do I come again?
Yeah, for the next session, if I inject for the younger patients, no need to stimulate more, I inject once a year. But for the older people or older patients, maybe 6 months, every 6 months.
Okay, thank you.
You're welcome.
Yes, I have one question. Have you constated that with calcium hydroxyapatite, you can have more bruising and more edema than with hyaluronic acid. I saw that in my practice sometime with bruising during 2 or 3 weeks and pain during shower under hot water.
For me, in the Kaha and also Kaha with the soft filler that I mix in the protocol, it's still swelling. It's quite swelling about 2 to 3 days, and bruising can be occur, but not so much in my case. But for me, I prefer the patients not to exercise like weight training or heavy activities because it can cause the delay bruising and delay pain and motion.
For how long you ask them not to exercise?
2 weeks.
2 weeks.
So I have one question. So you have many modality to do the hand revitalization, rejuvenations. Which indication that you use in each modalities, especially from the RF?
I will classify the patients to the severity. If the mild severe, I prefer to use the bioremodeling modalities like PN, collagen, or soft HA fillers. But if the patient has more severe or need more aggressive treatment, maybe the volumization HA may be preferred. And I always combined with the RF because that machine is the one that I use because it's, as you know, it's the patent technology that it can move freely on the curving area. Because if you use a normal RF in the market, it can easily to get burned.
Okay.
And also
Thank you.
ultrasound is burn also.
Okay. Thank you, Dr. Sumatra, so much for your very inspiring and impressive results. Then we move to the second speaker, Dr. Paisan Rammanithorn
Hello.
from Bangkok, Thailand. He will tell us about the topic, the amino acid injection for hand regenerations. Please give him a big pause. Thank you.
Thank you. Good afternoon to our chairman, Dr. Sakin. So my topic today is the amino acid injection for hand rejuvenation. Actually, Dr. Nataya has already covered so a wide variety of the products in the market right now. This is my disclosure. As we know, the amino acid is the main component of the collagen. Now, at least 28 kinds of the total of the types of the collagen that is in our body. Type 1, 2, 3, 4 is the most common. The type 1 of the collagen is the most abundant, supporting the skin, the bone. Type 2, type 3 aids for the organ structure. Type 4 support the skin layers. And approximately type 1 have approximately 90% found in our skin. Type 2 mainly in the cartilage. 1 and 3 is the most common found in the skin. For the structures of the collagens is containing the amino acid, hydroxyproline, proline, glycines, also with the structures of these amino acid that shown them in a monomer. So the molecule coupling from the amino acid form and become the polymer. The hydrogen bonding takes place between the oxygen and the hydrogen bond. So when the glycine, alanine, leucine binding into the strand of the collagen, that is the main structures of the dermis, they form the triple helix. And lastly, bunching into the big fibers. The ingredient, there are commonly glycine, proline, lysine. That's the structures of these dermis and enhance the fibroblast collagen synthesis, support the collagen cross-linking. L-alanine support the dermis protein synthesis. Serine, leucine, isoleucine, valine. This is all the quite a essential amino acid that form in the collagen. Now we go to also the elastin fibers. It's caused the elasticity of the skin, the recoiling of the skin. The fibers are essential protein-based component of the extracellular matrix that provide elasticity and recoil to vertebrate the tissues, allowing them to stretch and snap back to their original shape. The composed primarily of the elastin protein fibers are crucial in all many structures in our skin. So elastin fibers also is contained in the monomer of the amino acid. Over 75 to 80% of the sequence consisting of the glycine, valine, alanine, and proline. So somehow component of the amino acids is different. The glycine occur frequently, third or fourth, allowing for the close packing and flexibility. The valine, lysine, desmosine, and isodesmosine is also one unique cross-linking amino acid found only in the mature elastin. So this is a cross-sectional fiber thereafter. This is a product that is available in the market for the amino acid. There are now 4 kinds. I would like to make it like a product, F, S, X, and there are wide variety. Some product, for example, product X, FSB, they contain 9 amino acids. And inside, also they have the fragmented HA. The product OX has 8 amino acids, with also 1 milligram of the HA inside. The one that I'm using for the hand is the red one. The red one here, containing 3 major amino acids, glycine, proline, lysine, and down to the HA, 1 milligram per mil. However, for this product, they contain more concentration of the amino acid, up to 220 milligrams. After that, we have some SK, 2 SKU product. We have the product J something, another 3, and they are all containing variety of the amino acid inside. However, all the product here, we have the HA inside as well. Another one is a cell, is a B product from here, but they contain more milligram of the HA. This is the most number of this HA. So for the product we are mentioned, we are thinking that this is the working of the amino acid or the HA, which is working for the hands result. So I would like to give you this is some study, the efficacy of this HA fragment with the amino acid in combining facial skin aging and ultrasound and histological study. And they found out that the combination of this HA and amino acid improved the skin quality through the dermal regeneration and collagen stimulation, not the volume augmentation, because they contain just a little amount of the HA. And also this is another clinical investigation of the HA fortified with the amino acid for facial aging. It's all come out quite a positive result. Evaluation of the efficacy and safety of the HA and supplemented with amino acids and glutathione and choline for the prevention, treatment of the wrinkles of the face, neck, décolletage, and the hands. So the product that we are using this, but we move to the hand area. Again, the role of the HA and amino acid against the aging of the human skin a clinical and histological study. So all have the positive rejuvenation by restoring dermal biology and structures. So there are some expert comment. If we want to restructure or make a collagen fiber, do we need to supply? Since if we want to build a building, we have to put everyone bricks together. That may be too far away. But for their study before show us that it has the result. But somehow they still combine little amount of the HA that I put the question in. For my technique, we are using the cannula number 22 and going into the subdermal layers. So that's the same as Dr. Suntani showed us. So the dilution coming with the 9 ml that I mix with 0.75 of the lidocaine. So we mix the lidocaine in the product. And we go slowly. So you have to go through the subdermal layer in order not to puncture into the vein. And you go slowly, retrogradely, push the product slowly. For one hand, we inject 2.25 ml for one side. That contain half of that 220 milligram is 110 for one side. For the technique, depends on your preference. Some wants to move for the dorsal of the hand, and some you can starting with from the web of the hand. But from the web, we might want to do. Oh, sorry. So from the web, we might want to do 2 or 3 holes in order to complete the whole hand. And the important point is we have to, after the injection, we have to massage thoroughly to spread the product. However, we don't need to do it so rigorous like some particle, like CAHA, calcium hydroxyapatite, or PLLA or PDL. That is the high particle product that we have to squeeze it or mold it homogeneously. This is like more fluid, so it can spread more easier than the particle products. So we have to go cross and stay superficial, retrograde, and pushing the product one line. For me, is about 0.2, 0.3 ml for one line. But in case that you can cross the border to cover your entire hand, so it's okay. Just push or put the products homogeneously all over both hands. So this is the result before, oh no, sorry. Before and after. Again, for the dry hand, this is 2 months after the treatment. The products 0.5, 1 half vial of 9 ml is a 2.25 ml plus 0.75 lidocaine per hand. So 2 hand, we can see the firming, maybe the HA working on quite well. The fine line, we can see it is a bit less. I'm sorry. A bit less. This is another case, 35 years old lady with some roughness and mild wrinkling of the hand, and this is the same before and after the treatment. Pardon me? 1 minute left. One treatment.
So 1 minute left.
1 minute left. There is no serious side effect found, just maybe a little swelling, that's it. Okay, thank you for your attention. Thank you.
Thank you, Dr. Paisan, for a very interesting sessions, and we will leave the Q&A behind after all the presentations. Then may I introduce Dr. Gilbert Sarkin, who is going to tell us more about ethic consideration regarding fillers. Please give him a warm welcome.
Okay. So in African and Métis patient, if indication of cervicofacial lifting are later, there is no less request and indication in aesthetic medicine. So the specificity of the skin and facial tissue influence the aging, we know. This is example of facial lifting. The point? No, okay. Okay, so we have from the first one, it's a very thin skin, and we see with a thicker skin, we have to take care of the quality of the skin, and we can do also facelifting on Métis patient. It's very rare on African patients. It's extremely rare because the skin is thick, but in Métis patient, it's totally possible. So in medicine, in aesthetic medicine, which fillers to choose for dark skin or Métis population? Must we use low or high G prime? Must we use long-lasting filler? So we know that the different phototypes give different type of aging. You know better than me the skin, and you know that it's a protective element which allow exchange. Thanks to the keratinized layer, the epidermis has a protective role. The melanocytes are in the deep layer of the epidermis, in the basal membrane. This is melanocyte. We know that there is two types of melanocyte, eumelanin and pheomelanin. Pheomelanin is a yellow-red color pigment, and eumelanin that is more protective against the sun. There is the same number of melanocytes in all the type of skin, in all the race. But which is different, it's a percentage of eumelanin and pheomelanin and the activity level of this melanin. So this is a protective role of this. So quickly, Caucasian skin, first signs of aging, approximately 30 years. We can have facial variability, and we have to take this in charge. For example, we can have prominent cheekbone in Slavic people, different nose types, different type of fullness of the lips. In Hispanic and Mediterranean skin, the first skin of aging, approximately 35 years. The skin is darker and thicker. The nose can be larger with a more convex dorsum. The lips can be more full. The cheek must be more strong. In Asiatic skin, the first skin of aging become at 40 because the skin is thicker. And often we have variation, obviously, masseter hypertrophic. There is a good cheek definition, better than in Caucasian. There is a lack of eyelid crease, there is epicantral fold sometime, and the face is more round. For black and Métis skins, the skin is more thick. The dermis is more compact, and the first sign of aging often appear after 50. There is fewer fine lines and more furrows to treat. So the treatment become later, but sometimes it's more difficult to treat. And we have obviously a great variability in the nose and in the lips. So we have to take care of this, all this variation, because the ideal shape of the face varies considerably among population. Each ethnic group has their own beauty criteria. And if the nose and the lip are the most variable, cheek and lid are also influenced by racial or ethnic anatomy characteristic. And we have to consider that to answer to a beautification demand and to respect the ethnic criteria. Maturi distinguish 4 groups: Caucasian, Mediterranean, Asiatic, African. I will follow this classification, and obviously, actually, there is a lot of variation and a lot of cross and mixed with all this race, and majority of people belong to several influence, obviously. So we will see the several indication with a different kind of skin. Firstly, the nasolabial fold. This is an example of Caucasian patient with a thin skin. I used a low G' hyaluronic acid for the nasolabial fold. Here, it's a thicker skin, Caucasian people also. I use a medium high G' hyaluronic acid. The same for these cases with deeper nasolabial. This is a Hispanic people, but with thin skin. I use medium G'. This is a Kabyle patient. It's a Caucasian, but we come from Mediterranean area with intermediate skin, so medium hyaluronic acid. I used for darker skin, here it's an Indian origin woman, very often calcium hydroxyapatite. I like this product because it gives good volume, and I think it's very efficient to treat deep furrow and thick skin. You see the result of the treatment of the nasolabial fold with only 0.4 milliliter in each side. So it's we can use less volume of product with calcium hydroxyapatite. This is high G' hyaluronic acid for the nasolabial fold. It's for a patient with South American origin, a patient, Creole patient, so it's with black and white origin. And I use high G' hyaluronic acid in this case for the nasolabial fold. Same for this patient. It's a medium G' hyaluronic acid because it's a mestizo patient but with a thinner skin. Another patient was treated by polylactic acid for the cheeks and cheekbone. I G' hyaluronic acid for this patient. I treat, you see the jawline. This is nasolabial fold, calcium hydroxyapatite. Another cases, I go faster. Okay, I go faster. This is difficult cases, and I used polycaprolactone in this case to treat the nasolabial fold. Sometimes with African patients, we have a very expressive face, and it can be very difficult to treat. You see how the nasolabial is deep. So I use in these cases also calcium hydroxyapatite. This is a difficult case also because we have deepness of the nasolabial, and we have obviously ptosis, beginning of ptosis of the cheek. And with that, it's obviously more difficult. So I use calcium hydroxyapatite also, and this is a male with 65 years old, so old man with dark skin and thick skin is the most difficult to treat. The nasolabial fold appear very late, but it's very difficult to treat. So here I use also calcium hydroxyapatite. This is combined treatment. Okay, now the teardrop, the lower eyelid. So I won't give description of my technique of injection because it's not the subject and it would be too long, but I inject under the muscle in contact of the bone. And I go retrotransant. So I use a low G'. It's very important in this area to use low G' with non-hydrophilic effect. Metis patient with low G' hyaluronic acid. you see. So in all the cases, I'll go quickly because in all the cases involved for thicker skin, I think it's important to use only low G' hyaluronic acid for palpebral inferior. Okay, oval and mandible now. I won't describe the technique, you know that. This is the high G' to project the mandible and the angular angle in the Caucasian people. In other cases, Caucasian people. In male, the technique is a little bit different. I do injection like that. You see, it's orthogonal, but I go more lateral in women in order not to make the face too masculinized. So I use the high G' hyaluronic acid, and you see the improvement of the chin and the angle. Another patient, Hispanic patient with thin skin. IG prime. One more minute, okay. So Métis patient, I use IG prime, hyaluronic acid for the jawline. This is for jawline also. Jawline. The lips now, there is a big variation of the lips. The ideal ratio, it's a lower lip, 1.6 more than the upper lip. And we have big variation of the volume. This is Caucasian people. This is Caucasian people also. And I use hyaluronic acid specific for the lips in all the cases. This is Iranian people. This is the Mediterranean people, you see, with more full lips. Métis patient. Brazilian patient. Also Brazilian patient. Another Peruvian patient, mestizo patient. You see, we can use the hyaluronic acid to have bigger lips, even in African patients. Sometimes they want to have really big lips. Cheekbone with hyaluronic acid and polylactic acid. I use this combined treatment, and I like very much polylactic acid to improve the cheek and the jaw. This is Brazilian patient. Métis patient. The nose, I go quickly. I'm not going to describe the different type of nose. We know that there is a lot of type of nostril with different rays. Caucasian nose, it's less projecting, minor flaring. The tip is thin. Mediterranean, the tip can be more big. There's a thin fibrofatty subcutaneous layer. Asiatic nose, we know it's a short tip with less projection. And African, the tip has less projection, and there is a thick fibrofatty subcutaneous layer and large nostril, tip 4, 5, 6, and 7. Okay, so I will go faster and conclude up. So for the indication of injection, I don't describe that. Take care of the vascular anatomy, obviously. When you inject the nose, this is example of Caucasian patient. This is a Métis patient. I treat the concavity with medium G' hyaluronic acid. And for the columellar treatment, this Mediterranean patient, also a Mediterranean patient to improve the tip, and a Métis patient. In conclusion, Métis and African patient have a thicker skin, deeper furrow, later indication in surgery and medical treatment. So I propose to use thicker hyaluronic acid or slowly resorbar product for this patient, and obviously respect the antibiotic criteria. Thank you very much.
Thank you, Dr. Zakeen. I will take questions at the end. Dr. Kim will now speak on PDLLA HA for hair restoration, mechanism of action, and real-world clinical outcomes.
Right, thank you for introducing me. Okay, good afternoon, everyone. Today, I prepare the PDLLA and the HA for the hair restoration. So as you know, there are lots of some things. Now they're focused on the face, rejuvenations, treatment, but we can broaden the indication about our good polymer for the lots of some indications. So that's why, first of all, some company revealed the PDLLA combined with the free HA for the hair restorations. Then I will prefer the clinical outcomes. So this is my agenda. As you know, the PDLLA HA has more generated effect compared to the other PDLLA CMC or PCL CMC or CAHA CMC or some other CMC one, because it's more gentle effect compared to the other thing. It's by own characteristic about the PDLLA also and HA effect. So that's why they have more focus on not to be make the strong effect, but more rejuvenation, more regenerative effect when they got inserted. So here's the mechanism of the actions. As you know, from the step 1, the direct particle and cell interactions will be happened. As a step 2, the mechanotransductions, they activate the PH1 receptors and the calcium will influx into the cells. As a result, they make a signaling by the M2 polarization for the very good effect about to our skins. So let's move into details about these things. When you got the inserted the PDLLA HA particles into our skins, they make mechanical forces. So as we already know that from the last of some talks, when the mechanical actions will be evented, PH1 activations will be gonna be started. So as a result, when the PH1 or the other signals are influxed and making a new cascade, so our M1 macrophages, which have some contribute to the pro-inflammatory one, to move to the M2 one. It's more pro-regenerative one. So that's why they're gonna be make the lots of the signals to our skin cells from the dermal layers. They have some lots of some dermal rejuvenation stated, and the subcutaneously they are gonna make the adipogenesis effect and sculpt. They're gonna be the more effect in the hair rejuvenation and peri-hair follicular environment rejuvenation way. So from in the past, lots of some PDLLA HA are focused on to the like these things, the dermal rejuvenation and the subcutaneously. Now we can broaden the indication from the scalp treatment also. So and you can see for the details of the hair rejuvenations, they restore the microenvironment of the balance in the scalp layer. So they can contribute into the hair restorations and also hair quality improvement. So here you can see when the M2 macrophage, AGF and the IGF-1 are unregulated, so that's why they have some good effect to the hair follicular cells, and so result the hair growths will be more evented. And the number 2, they reduce the ROS oxidative stress. So as a result, dermal papillae cells and hair follicular keratinocyte cells more activating and more good environments compared to the before the treatment. So that's why they contributed the hair quality improvement. So for the details by the hair growth, when there's some PDLLA HA inserted into our skin, they activating the piezo, so that's why the M2 polarizations, and by that way, they activating the raster signaling. So it's very key things about the hair rejuvenation. So that's why they activating the Wnt-beta-cascinin pathways also. So as a result, our hairs will be more regenerated by these features. You can see that the PC-ANCA and the K55 was more stem cell activation markers more elevated after the treatment. So there's some table sees that the hair follicular stem cell number is 88%, 88 times higher than the before the treatment. So it's very, very remarkable changes for their hair cells and the hair environment. And you can see hair follicular stem cell numbers are also 3 times higher, and diameters of the hair follicles will be also 3 times higher, and length of the hair follicles also gonna be improved 3 times higher. So they can contribute it not only for the number of hair follicles and also affected onto the hair growths. So lots of treatment, when they gonna have some effect, they gonna be checked by the new vellus hairs only. But the PDLLN and the HA can be contributing onto the real hair growth. So here's the comparable treatment compared to the cell line and the PDLLA HA. You can see the differences by the visually and the histopathologically. So let's move on to the quality improvement treatment. You can see not only for the one thing, they reduce the ROS. So as an end result, not only for the dermal papillae cell only, hair follicular keratinocyte and sebaceous gland and melanocytic stem cells, all of these cells has some good beneficial effect from the PDLL and HA. So let's for the detail first for the dermal papillae cells first. So when they reduce the ROS like the 46%, they have some good effect to the dermal papillae cells. So here's the result. You can see proliferation ratio is much more higher, and the IGF-1 secretion is also higher. You can check by these immunohistopathological things. And hair quality improvements. So when the IGF-1 secretion is elevated, hair follicular keratinocyte proliferations will be also gonna be the increase. So that's why they have some affected in it, not only for the outer root seeds and also affected into the inner root seeds also. So that's why our hairs looks more thicker than before the treatment. So here's some things done by the histopathological studies. You can see the hairs are more thicker than before the treatment, and by some EM images, the hair is more thicker than before the treatment. So it also has some effect about the hair thicknesses also. And the hair shyness. So even though the hair has so many numbers, the hair does not shine, it looks better. But when they got some PDLL and HA inserted, they're gonna make the sebaceous gland more bigger. So as a result, the sebum productions will be more higher. So that's why their hairs looks more shines. And lastly, I think it's kind of some more promising things and need more specific studies should be conducted. But it also has some chances to make our early graying of the hair. You can see when the ROS stresses and reduced, the melanocytic stem cells also can be activated. So as a result, here's by the photos by the mouse's back, you can see the gray hair zone is much reduced compared to the control air. So it can be one of the promising options about for the early hair graying. But to be honestly, I think it should be more needed, more studies should be done to be more confirmed about this result. So let's move to the treatment protocols. So when you're using the needles, using the PDLL and the HA, 6 millimeters dilution is kind of the more standard thing, and using the 30 gauge with the 4 millimeters needles and microbolus injection techniques should be done. And this is my technique. So I made some 7 centimeters higher from the eyebrow. So because, as you know, the diagnosis criteria for the hair balding is starting from the 7 centimeters higher than to the eyebrow area. So that's why I draw the line from that area and more rectangulars into the temple area and inject it by this way. So total 40 points should be kind of more optional and ideal. And if per injection point 0.1 cc is enough. Then total volume in the 4 in the scalp area, and then using the another 2 into the hairline area will make some changes. So we have to target into the deep dermis and the superficial subcutaneous area, and there's no minimum distance required between the injection points. And most probably, when the needle feels not so smoothly, you have to change the needles, because in the scalp area, it's very sensitive for the pain injections, so that's why we have to be frequently changing about needle for the patient componentness, and some in vertically 2 millimeters to target the correct depth. And if you take some hurdles to using the needles, other EBD can be another options. When the time I'm using like these kind of the things, but it's only for the one needle jet-free injection lasers. So another laser should be needed more studies. But you can see that more than 40,000 shots should be needed to using the 3 millimeters volume of the PDLL and HA. You're right. So this is the last clinical results. You can see when you're using the androgenetic alopecia and the hair thinning and the female pattern hair losses can be deal with the PDLL and HA also only. So in this study, I just using the PDLL and HA only. So in my clinic, I combined with lots of the cytokine, lots of kind of cytokine or some exosomes or some other like the chitosan. So lots of things can be done when you're dealing with the hair treatment. But for this study, I just truly use it just the PDLL and HA only, and here's the 2 times after changes. For the male hair thinning cases, you can see the differences with after the treatment, and male pattern hair losses will be more thicker hair follicular and hair size, and the more thicker and more density about the hair size and hair numbers can be figured out. You can see male hair thinnings also can be treatable with these things. This is female pattern hair losses. You can only the 2 times after, you can see the dramatically changes can be achieved. The last cases is hair thinning cases for the females. You can see the differences about these things, not only for the hair numbers, but also hair shines. And you can see her hair is more shiner ever than before the treatment. You can see the differences by the pictures. So this is my last slide. You can see when you're using the PDLL and HA in the hair follicular area, you can see not only for the improved hair cuticle intensity and the surface morphologies, but also they can be affected on the hair shaft keratin formations, and they have some effect about support of the hair follicle functions because they're going to be make the new collagens when they're inserted the area, and they also have some effect in the increase of the hair thickness and the follicular size, and potential prolongation of the anagen phases, and improve of the scalp microenvironment. Okay, this is my last slide. Thank you for the listening.
Thank you. And then we move to the Q&A question. If any delegate have any question, please feel free to go to the microphone here and have some question with our speakers. Yeah. Meanwhile, we have very limited of time, so I would like to ask Dr. Kim. Okay. So how, since you said that you have so many modalities to treat with the hair baldness, so what kind of case that you choose PDLA over exosome or PRP?
So to be honestly, when we can miss lots of hurdles when dealing with the hair baldnesses, right? So because not only the one factors, but lots of some factors can attribute to the hair baldness. Some patients need some like the inflammation on their hair area, and some patients needs more make the thicknesses of the dermal layer, or some patients more needs some like the hormonal therapy, making like the 5-DHA, the agonist one, like the phenyl and the dutasteroid. So in my opinion, when you're dealing with the hair follicular treatment, not only for the one modalities, but we needed more like the mixture types and mixture cocktails for dealing with about the things. So today my presentations I prepared not only for the other like the conventional modalities, but also the PDLLA HA have some one other cocktails options for the treating of the hair baldness.
Thank you. Dr. Paisal is not here. I had a question for him. Dr. Zakeen, I have a question for you. In the nasolabial fold, you put Kaha. What dilution did you use? Dilution.
I don't do dilution because I use calcium hydroxyapatite with lidocaine inside.
Okay.
Yet. So I don't do dilution, but obviously I use cannula. I've not the precision. It's important to use cannula because there is a vascular risk, and specifically with hydroxyapatite of calcium, there is no hyaluronidase and no possible treatment if there is a vascular impairment.
And the eyelid, the lower eyelid you used, did you use a cannula there or a needle for HA?
I prefer needle, but I know that it's there is controversy, and there is a lot of people who prefer cannula. So I have, in my hand, I use needle, but the both is possible. But it's important to be deep.
Okay, thank you. Any questions from the audience? Otherwise, I think time for the next session.
Thank you so much, all the speaker and delegates here. Hope you enjoy your stay in Bangkok, and let's meet our next speaker and in next session. Thank you.